So I'll be talking about the real-life experience for Xolair or omalizumab in pediatric asthmatic patients. First of all, I'd like to thank ETS for organizing this meeting and for having me. I'd like also to thank Novartis for sponsoring this symposium, and thank you all for being here. And I promise I'll try not to be too chatty. So we'll go over the role of IgE really quickly and talk a little bit about why we want to target IgE in allergic asthma. And I'll spend more time talking about omalizumab in pediatric asthma. So when we talk about IgE at the basis of all allergic diseases, you all know this. This might be a little bit redundant. But upon exposure to allergen, your dendritic cells will basically skew your response, your immune response, to a Th2 response. And that will trigger a cascade of things and inflammatory cytokines such as interleukin-3 and 14. You'll have more IgE productions. And then these mediators also will lead to an inflammatory milieu. And you have basically eosinophils as well, infiltration and activation. Upon re-exposure to an allergen, basically you will have release of all the inflammatory mediators, and that would lead to several different things that you see on the right. You'll have smooth muscle contraction, you'll have increased permeability, activation of eosinophils that I mentioned, increased gland secretion, and also increase in nerve endings. And all of these changes are at the basis of several allergic diseases, as you can see here: asthma, allergic rhinitis, ABPA, food allergy across the board, and then on your right hand, the chronic spontaneous urticaria and dermatitis. Now, omalizumab targets free IgE, and the rationale behind this is when you're targeting your IgE, you're basically rendering your mast cells more stable, and then so you control their activation and you make them more stable and you decrease the threshold. You also can block all the inflammatory cytokines and the eosinophil mobilization and infiltrations into your tissues. Hence, we can control everything that I just mentioned in terms of smooth muscle contraction, permeability increase, and all the other changes that we see. Now, despite nearly literally 2 decades of successful usage in adult, the data of omalizumab use in children is really still very limited. And when I say allergic asthma across the presentation, and this was really nicely delineated in some of the presentations earlier, so we talk about basically allergic asthma in the sense of abnormal activation of your immune pathway leading to an underlying area inflammation. And the 3 different types usually are the Th2 patients, where you have elevated IgE and eosinophils. You have the neutrophilic asthma and the polygranulocytic asthma. And in kids, most or the majority of patients with asthma have the Th2 allergic asthma. And omalizumab and the GINA guidelines that were nicely presented earlier, it is recommended as an add-on treatment for children more than 6 years with uncontrolled moderate to severe asthma. Now, we have some evidence that has demonstrated the efficacy and safety of omalizumab in asthmatic patients, and I'll go over them one by one, show you the evidence behind it. We have some indication that it improves asthma symptoms and quality of life in pediatric patients. So in this case series of 8 patients aged less than 12 years, and these were patients that were followed up for 2 years, omalizumab resulted in 2.5 times increase in their average asthma control test over the 2-year follow-up. You can see the difference between a score of 7.8 and a score of 21, which means that your asthma is more controlled. Omalizumab also has shown to decrease exacerbations and hospitalization for acute asthma attacks. In the Xolair study, which basically was a retrospective real-life study conducted in France, they looked at patients aged 6 to 17. And this study showed that there was nearly 80% of patients who demonstrated more than 40% reduction in their annual exacerbation rate. That was only after 4 to 6 months of treatment with omalizumab. So that's a quite significant finding. In the same case series that I showed earlier by Skepko and et al., basically also Xolair or omalizumab resulted in a decrease in exacerbations with an average of 20 per year of exacerbations to 5 exacerbations, and that was quite significant. In another study, which was published in Allergy and Immunopathology in 2019, this study looked at patients over a 4-year period, and it was a single-center real-life study looking at all pediatric patients less than 18 years. And omalizumab reduced the number of visits to the ER department due to asthma exacerbations consistently, and you can see the p-values at year 1, which was statistically significant throughout all 4 years of follow-up. We also know that omalizumab can abrogate lung function decrease. And this was published in the Journal of Allergy and Clinical Immunology in February 2020. This was a retrospective survey of 10 patients with severe asthma, and their age was 6 to 14 years. And these were patients who were treated with omalizumab followed for 2 years. And what we see here is
Hi, Dr. Marilyn Karam.
Interruption.
point to a positive basically number, which means improvement in your FEV1. Now, the other evidence that we have is also reduced or stopped inhaled corticosteroid use. And again, in this real life study, single center experience, 48 patients, with severe uncontrolled asthma were looked at. And here the follow-up period was 6 years. You can see that the mean dose of fluticasone use over treatment has decreased from the graph. It decreased from 452 micrograms per day to a 330 approximately micrograms per day after 6 months only. And this reduction was maintained throughout the years of follow-up. Now, I wanted to also mention, these are not usually things we talk about when we talk about omalizumab, but I think these are interesting, especially in the pediatric population. And this the additional insight is we now think that omalizumab might have enhanced antiviral immunity. And the reason why we think that is because of the PRO study. So we all have seen a seasonal peak in asthma exacerbation rates in the fall, and we've always attributed this to kids going back to school. So it's really both an increase in allergen and increased in virus exposure. So in this specific study, the PRO study, which is the preventive omalizumab or step-up therapy for fall exacerbations, this was a study that looked at 513 kids with mild and severe asthma. And they were given an injection of omalizumab over the 4 to 6 weeks before going back to school. And when you look at the first graph here, you see that 20% compared to 20% in the placebo group, only 11.3% in the, only 11.3% in the omalizumab group had an exacerbation within 3 months of going back to school. Also, when you look on the right here, your right-hand side, we see that when we looked at the rhinovirus induced interferon gamma levels, so our immune system naturally, when you have rhinovirus, it increases the interferon gamma levels. So in the omalizumab, the improved interferon, there was an improved interferon gamma production specific to the rhinovirus. And when you look within that omalizumab subgroup, you can also see that the higher the increase in interferon gamma, the fewer the exacerbations. The other thing that we need to also keep in mind is that we want to try to start thinking about omalizumab as a disease-modifying drug, and we've seen some of the evidence. So omalizumab can disrupt a key element of the allergic inflammatory cascade, so it can improve the management of asthma and reduce the development of multiple allergic comorbidities. And it may have the potential to attenuate and reverse remodeling, because that's really very concerning in uncontrolled asthma. So when we talk about uncontrolled asthma, we want to prevent the long-term fibrosis, I call it, that happens in the lung, or the remodeling is the better term to describe it. So using omalizumab has been linked to attenuate and reverse that remodeling that we want to avoid. I did also want to mention a very nice study that is currently being done. And this study is still in the recruitment phase, and it will hopefully be done around in November 2025. And this is a study that is looking at high-risk 2 to 3-year-olds. So this is called the preventive asthma in high-risk kids, and it's really designed to examine if we give kids 2 years of omalizumab treatment, if that can reduce the risk of progression to persistent asthma and asthma exacerbation, the number of new allergic sensitization and wheezing episodes in these patients. So kind of basically stopping the allergic march or the atopic march that we were talking about previously in the previous talks. Another indication that this might be a disease-modifying drug is using it in food immunotherapy, as was mentioned previously by Dr. Ahmad. So that also could indicate towards this theory as well. I would like to end my talk by presenting this study, which is basically a post-marketing surveillance study looking at the long-term safety and effectiveness of omalizumab in a Japanese pediatric cohort. And this was a multi-center surveillance study conducted over 104 weeks, so over 2 years, from September 2013 to May 2019. And patients were aged 6 or more and less than 15, and they all had severe allergic asthma, and they were first-time users of omalizumab. There was 2 main endpoints they wanted to look at: safety and efficacy. So the primary endpoints were incidence of adverse drug reactions and infection, and physicians' global evaluation of treatment effectiveness scores. So basically, and I'll talk more about this GET score. The secondary endpoints for safety, it was incidence of serious adverse events and concomitant allergic disease. And for efficacy secondary endpoints, that included asthma exacerbation-related events and the effectiveness of Xolair by patient characteristics. Now, most of the adverse drug reactions, so that happened only in 13 patients out of 127. And the most common adverse drug reaction was pyrexia in 2.3% and urticaria at the site of injection. Serious side effects were really very minimal. Only 2 patients had anaphylaxis, One of them was actually specific IgE anaphylaxis to omalizumab, which was extremely rare. Now for the physician GET score, so when you look at the chart on your right, everything in blue and red is acceptable. And when you have a score of excellent and good, that means that you are on an effective therapy as per your physician's assessment. And at the final assessment of these patients, almost 80%, so 77.17% of patients had an effective had the final assessment as effective. So omalizumab was effective for their severe asthma. And there was also overall, here you can see on the right side, there was overall decrease in the proportion of asthma exacerbated related events comparing pre-treatment to post-treatment. So in summary, this basically the study that I'm showing you here basically indicates no new safety signals with long-term omalizumab treatment, so similar as in adults. The effectiveness was also determined or demonstrated in terms of GET, increase in asthma control, and decrease exacerbations. And the safety and effectiveness profile basically is consistent with all other previous studies. Now, I'd like to say thank you and conclude basically by saying that the reason why we don't have a lot of data on omalizumab, I mean, it's premature to say we have enough data, but that's because parents usually shy away from giving injections to their kids. But as time moves on, I think this is going to change because we're definitely seeing some promising results. And I'm eager to see what the next couple of years will give us data in terms of effectiveness and safety in kids. Thank you.
Thank you very much, Dr. Marilyn. That was interesting. And I think enlightening to a lot of the population the physicians who didn't start to use biologics yet in children. There is a couple of questions. The first one is, what's the most common side effect attributed to omalizumab in children? And what is the age limit to start it?
So it's approved in 6 and above. And then as I showed, it was usually just pyrexia, so fever, and local, so urticaria at the site. Same thing as in adults. So on the drug itself, the drug pamphlets, there's a risk of anaphylaxis, but the risk is really extremely low. So it's 0.08%. And really now it's even lower. That's why we monitor our patients for 2 hours in clinic for the first 3 doses. And after that, I monitor for 30 minutes.
Right. Now, the second question is that it's about the reaction and whether anaphylaxis can happen and whether it's advisable to do a test dose before using Xolair.
Yes, anaphylaxis can happen. It is not advisable to do a test dose. It's like any other medication. So you can be taking the same antibiotic over and over during your whole life and all of a sudden become allergic to it. So it's the exact same thing. The other thing is that it's worth mentioning that the FDA currently in the pandemic, the COVID pandemic, the FDA has authorized in-home use of omalizumab. So patients were able to continue omalizumab at home and not stop it and have to come to the clinic to get it, despite that, anaphylaxis risk. So it's really there, but it's extremely rare. It can happen, but it's not as common as people would think.
Yeah, I think the switch to the pre-filled syringes, that's the home use, have made a big difference. I mean, because
absolutely,
the patients doesn't need to come and made it really easier. Yeah, it's been really so far a positive experience with Xolair. Maybe that would be the way to go with biologics for children. It's just the injection, I think. That's the part where it's a little bit with children, but I see that they get used to it. They actually continue.
Absolutely, yeah.
That's very good. Well, thank you very much. That was wonderful. Thank you. for giving